Welcome everyone to our session today. We are super excited to have you here. So as everyone's joining, I'm just going to wait a few minutes and then we'll get started because we have a lot of great information to cover today and it sounds like a hot topic. It sounds like everyone wants to know about it. So we're super excited about getting started. It looks like it's going up pretty quickly. So with that being said, this is a CE session webinar. So we are going to go over some of the guidelines to meet the CE requirements. Number one, if you want CEs for this program, you must have registered in your legal name. And what I mean by your legal name is what is on your license. That's very important. Each person must send in their own registration. And also each person must sign on their own device because it's timestamped. So we'll know when you get on and when you get off. So it's really important to make sure that if you want CEs for this, that you actually signed on. Also, if you are using your telephone, as long as you click the link, you're good to go and you're watching it with us, we can see that. However, if you're dialing in on your telephone, we can't see that. So what we're going to ask you to do is please send me your name, the title of the course, and your telephone number because your telephone number does register and we'll be able to cross-reference those and give you credit. You will send those to practicecoaching@benco.com. Again, that's practicecoaching@benco.com. And we'll go over that at the end if you missed it, so don't panic. With all that being said, it takes about 30 days to receive your CEs. We're also going to be sending you a survey. We definitely want your feedback. Let us know how you think we're doing. And also any other topics that you might want us to talk about on our webinars, please send us those comments. We really want to hear them. And then if you'll notice, down below you have a Q&A. We would love for you to ask questions during the webinar. So if for any reason we don't answer your question live, we will answer all of those questions and everyone attending today's webinar will receive the Q&A for all the questions that were asked today. So with that being said, I would like to get started. I am honored to introduce one of the most hardworking, inspirational leaders in the dental field. That is the Managing Director of Benco Dental, Chuck Cohen.
Oh my God, Kay, go on, go on. Thank you very much. Welcome everybody, we're glad you're here. Most importantly, we're glad to welcome Dr. Mick Falco, an old friend of ours at Benco and a longtime acquaintance of mine, who's going to talk about one of the most exciting technologies out there. I'm not going to steal his thunder, so he'll talk to you about it for a few minutes. What I do want to say before we get started is he is a real actual dentist who does real actual dentistry, which is unusual sometimes these days. He is working chairside. In fact, today he's in his office delivering this webinar. His product is one of the most exciting products, and it was a very exciting product pre-COVID. Today, it is one of the most exciting products out there. It's on pharma, it's Onset, and he's going to talk today about why Onset makes even more sense today in a COVID-19 world than it did before. With that, I'm very pleased to turn things over to my friend, Dr. Mick Falco.
Well, thanks, Chuck. I really appreciate it. And I really appreciate everything you're doing at Benco to make this post-COVID new normal more accessible and educating the dentists that are out there and the whole dental teams, because it makes a huge difference. So thanks for doing that. Yeah, my name is Mick Falco. I'm a general dentist in Monterey, California. This is the 7th hole at Pebble Beach. This is our neighborhood. And so I've been lucky enough to practice here for over 30 years. I'm still in practice. Like Chuck said, I did dentistry this morning. And I will do some after the lecture. Since it's California, it's only 10 o'clock in the morning here. I'm also the founder and chief medical of On Pharma. We brought Onset to the market. That's buffered anesthetic. I do teach local anesthesia at the University of the Pacific Arthur A. Dugoni School of Dentistry. And a little disclosure before we start. First disclosure is, like I said, I'm the founder and chief medical officer of On Pharma, so I clearly have a financial interest. So that's always good to know who's speaking to you. But the second disclosure is probably more important, and that is, we're getting a lot of regulations and so forth from all of these different organizations that are here. And what's important is that I can't be an expert in all of them, but we all need to be somewhat of an expert, and you should be doing your research to make sure that everything you are doing in your office now is what is recommended by all these different organizations. Your own state will have different regulations as well. So please make sure that you're taking a look at that because I think it's important. And I want to start with the CDC guidelines for dentistry. The CDC has said that the dental healthcare professional should be now seeing one patient at a time. So kind of they've said the days of jumping from patient to patient to patient to try to be efficient are behind us, at least in this post-COVID world. So going in, giving local anesthetic, running out of the room to go find a hygiene patient to check no longer can happen. What you need to do is go into the room and see that patient, complete the patient, and then move on. And that's a really big difference in the workflow in the office. And I think we're going to give you some idea of how we can make that effective for you today. So, using your personal protective equipment, it's still not easy to get everything that we need. So being able to conserve that is really important. Really important. So we need to be able to, what we like to say is seat, treat, and complete. If you look at this slide here, if the patient's on the right and we're on the left, we are protecting ourselves. So personal protective equipment is really important for ourselves, our own health, our practice's health, meaning our staff, and then when we go home at night for our families. So it's not just about protecting the patient, it's about protecting us. In California, we need to wear gloves, we need to wear a gown, we need to wear a mask, we need to wear a shield, and we need to wear a head covering. And we're supposed to change all of that for each patient. And that gets to be cumbersome. It's intense to don and doff effectively. So you want to do that as few times as possible. So what we like to say is you can seat, treat, and complete. And if you do that, you're going to dramatically reduce your PPE consumption. So if you're running out of the room and changing your PPE consumption and not finished your procedure, then you're going to have to re-don when you come back in to finish that procedure. So you're going to use twice as much at minimum of PPE equipment. You'll also be, if you run out of the room and don't change, you're going to be the vector for the infection. And you don't want to be that vector. You don't want to be that for your staff. You don't want to be it for the next patient that you're going to see. You want to be as safe as possible. And then possibly most important is that you need to run a business. You need to have the patient volume and the production to be able to run the business effectively. And if you are just seeing one patient at a time, you need to be very careful on how you do that so that you can be efficient and effective. I've been seeing one patient at a time because I've been buffering local anesthetic for over 10 years. And I will tell you that I'm a very efficient and very productive practice. And so, what I like to say is that I tried to solve a problem 10 years ago that people didn't really have. Now, everybody has this problem because we need to be seeing one patient at a time. And I'm going to give you an idea how you can seat the patient, give an injection, go right to work, complete the procedure, and then leave your operatory after that. You can do your hygiene exams between patients now, as opposed to within the treatment of one patient. So seat, treat, and complete is what this is all about. And we're going to be talking about a tool to do that, and that's pH buffering. So why would we want to buffer local anesthetic? Well, when I started this, really what I wanted is, and I wanted an answer to three things, really. The first was, I was taught in dental school, if you can give a comfortable injection, you can build your whole practice around that. And I will tell you that is absolutely true. I got known in town as the guy with the best technique. But when the anesthetic goes in, some people feel that exquisite discomfort, which is the acidity of the anesthetic. And that's a chemical problem, not a technique problem. So I wanted to be able to fix that. I also struggled with failed anesthetic. Every time local anesthetic failed, I took it personally, like I was doing something wrong. I think the patients think I was doing something wrong. So it really bothered me, the inconsistency I would have from patient to patient and even within the same patient on different appointments. And then most importantly, I wanted to be more efficient. I really didn't like the model of running around the dental office and seeing all of these different patients. I wanted to be able to sit down, complete my task, and move on. If you do that, you're 30% more efficient. So not only can you save the anesthesia time, but you can also be more efficient in the procedure that you're doing by up to 30% by just not being interrupted. So now we can fix the problem of seeing one patient at a time as it relates to local anesthetic latency. So local anesthetic latency is really all about the chemistry of the anesthetic, the way it's packaged as an acid, and the physiology of the patient, because the patient has to raise the pH of the anesthetic to the point where it works. Local anesthetic is packaged at about the pH of lemon juice. If it has a vasoconstrictor, it's packaged at a pH of about 3.5. And most importantly, local anesthetic doesn't take effect until the tissues have raised the pH up to 7.4, which is the body's pH. So this process takes time. So here's the question. When do we expect our local anesthetics to work? If you go to the package inserts and you go to the textbooks, you're going to see this 3 to 5 minutes on average for infiltrations and 5 to 7 minutes on average for blocks. Now, I had a problem with that because sometimes it would work like that in my practice, but rarely. And when it didn't, I felt like I was doing something wrong. So I wanted to know, where did these numbers come from? Well, I went back to the textbooks. This yellow textbook in the middle is Stan Malamed's very first textbook. Stan Malamed is the guru on local anesthesia around the world. And that's the textbook that I studied in dental school. And in that textbook, it gives you those numbers, but no reference. The textbook on the right is Stan's most recent textbook. It's the 6th edition, and it still doesn't give any reference. So I went to Stan and I said, hey, look, Stan, you give these numbers 3 to 5 minutes for infiltrations and on the maxillary arch and 5 to 7 minutes for inferior alveolar nerve blocks. Where did you get those numbers? And he said, I got them from my textbook. And I said, well, I know that. I can read your textbook, but it's not referenced where you got it. And finally, he said, look, I got it from the guy who wrote the book before me, and that's Mannheim. So that's the book on the left. So I went to Mannheim's book and I looked, and he didn't have any references either. And I wanted to ask him about it, but he had already passed away. So I went to the guy before him and I looked at his book and the one before that. And it turns out that these numbers go way back. As a matter of fact, it's almost like they're commandments. And so they go all the way back, and they're like these, it's like they're written in stone. So that made me feel even worse about the way local anesthetic was working for me, because I could not get it to work like that every time, not even close to every time. So I wanted to do a little bit more research and figure out what was going on. So when it comes to onset time, the book gives us these numbers. What do the numbers really mean? Because they do mean something. And it turns out they reference the start of soft tissue analgesia. So way back when, in the early 1900s, right around 1900 itself, Procaine came out. That's Novocaine. And dentists were never trained on it. There weren't any books on it. It just got started being used. There were no studies. And dentists would say, when they'd give an injection on the upper arch, they'd say, tell me when you start to feel numb. And that'd be around 3 to 5 minutes. And when they would give an injection on the lower, inferior alveolar nerve block, they would say the same thing, and the patient would say about 5 to 7 minutes that they were starting to feel numb. So that's where these numbers came from. But really, what we want to know is, does that give us any meaning for soft tissue analgesia when it comes to clinical dentistry and actually practicing? So let's take a look at this. I'm going to set this up by saying, when I was taught inferior alveolar nerve blocks in dental school, I was literally taught to give it my best shot after I learned the technique. And then I was to sit the patient up and have them let me know when they started to feel numb right to the middle of their lip and their chin, and also part of their tongue was numb. And at that point, I was taught to lean the patient back, pick up my sharp explorer, and stab them right on the lingual of the cuspid. Like that was the magic spot. And if they didn't feel that, I was told that they were stone cold numb. Well, this guy, Dr. Lai, must have been taught at my school, because he did a study back in 2006 with exactly that setup. And so if you look at the vertical axis, it's the percentage of times that you can stab the patient and be successful. And the horizontal axis is time over 20 minutes. And if we look at 5 minutes with lidocaine with epinephrine, you get 77% of the time you can stab the patient at 5 minutes and have them be comfortable. If you go out to 7 minutes, it goes all the way up to 86%. Well, that's pretty good. If you were successful 86% of the time with inferior alveolar nerve blocks, I think we all would be fairly happy with that. But here's the problem. This red line is pulpal anesthesia. So pulpal anesthesia is what we're looking to achieve to have patients be comfortable. So that's a completely different line. If we go out to 7 minutes and we know we have 86% of the time we can stab them, that should only be 45% of the time with pulpal anesthesia. Well, that's a big difference. So if you go in at 7 minutes and you have less than half of your patients numb, it's going to make you feel like you fail often. That's why treating mandibular teeth are so much more difficult than maxillary teeth. Well, this area between the curve is what I call the worst failure of local anesthesia in dentistry. And the reason for that is the patient thinks they're numb. They've lost control of their lip and their tongue. I think they're numb because I've stabbed them and I was taught that that was the test. And then as soon as we start drilling on the tooth, get through the old restoration or hit dentin, the patient jumps. And that jump ruins everybody's day. It's the worst for the patient, right? Once they've felt it, now they're going to be holding on for dear life for the rest of the appointment. It's bad for me. I've got sweat running down the back of my neck, and it even flusters the assistant. So it's kind of ruined everybody's day in the dental office. The other reason I call this the worst failure of local anesthesia in dentistry is because of social media. If you have a good experience someplace, you tell a handful of people. If you have a bad experience, you tell everybody you know. And now you can tell even people you don't know with social media. So it's a bad experience. We want to try to avoid that. So what do we do to confirm local anesthesia? And that's something that I think is really important, whether you buffer or not. Here are our tools. Well, we just sort of explained that the Sharp Dental Explorer is kind of not a very good tool to check for pulpal analgesia. So we'll scrap that one. You could go with endo ice. I think this is our best option. Endo ice is a refrigerant. You put that on a cotton pellet. You place that on the cervical margin of the tooth. And if they do not feel that after 5 seconds, they are numb. This is what the literature has gone to as the standard for checking pulpal vitality and checking for local anesthesia effectiveness. The last one you could choose is you could choose the electric pulp tester. Of course, this is kind of a kludgy instrument. You have to put toothpaste on the instrument for the conduction, and then you have to run it up. And if they feel that, if you get to the 80 reading, they're numb. And if they get to anything but the 80 reading and they feel it, they're not numb. But it's a little bit kludgy. So what do I use? I use endo ice, and I check every single patient because I want to start the patient as soon as they are comfortable. So what I do is we give local anesthesia, let the patient know what we're doing, and then the dental assistant hands me the endo ice on a cotton pellet. I place it on the tooth and ask them if they've had any sensation. If they don't have sensation, it's time to go to work. If they do, you can give them another minute and try again. And one advantage of buffering local anesthetic is if they're not numb at 2 minutes, you can give them another injection because you may not have been in the right spot. Saying that, even maxillary teeth, I give local anesthesia on maxillary teeth. I want to make sure they're numb because I hate it when people jump, and people hate it when they jump. So I test every tooth before I start working. That makes for a lot more straightforward day for me and a lot less stressful for our patients. So the book gives us these numbers. Do most practitioners leave after we give the injection? And the overwhelming answer is yes. Matter of fact, I've never asked a dentist and had them say no. So every dentist leaves. And the typical window, if you ask a dentist how long do they leave, they'll say 10 minutes. Some will go on to say 15 minutes. Well, why, if the package insert gives us 5 to 7 minutes, do we wait 10 to 15 minutes? And that's because we're always hedging our bets. We know that if we wait longer, we have a better chance. So let's take a look at this red line that we had in that last few slides ago for pulpal analgesia. Where did this come from? I call this the curve. And I want to know where it came from. Where it came from is we did a meta-analysis. So we wanted to look at everybody's data that had done the studies out there. And you have to get apples and apples, not apples and oranges. So for that, you have to use what we call inclusion requirements or exclusion requirements. In this case, we used inclusion requirements so that we could look at a study and say, this study could be included in our meta-analysis or it could not be included in our meta-analysis. So what were our inclusion requirements? 2% lidocaine with epinephrine, no response to an EPT, electric pulp tester, with an 80 reading, testing only mandibular molars and premolars. If you go out to cuspids and the anterior teeth, that the results for inferior nerve blocks go down dramatically. So we wanted to look at just molars and premolars, and we wanted multiple testing intervals over at least 15 minutes. Otherwise, we couldn't put it on a graph. So a lot of studies just test at one time period, 5, 10, 15 minutes, and we couldn't use that data. So that was excluded. It had to have multiple time testing over 15 or more minutes. So we found 34 peer-reviewed articles, and we took all of those articles and graphed them. And so this is all of the data from 1,344 subjects over a time period of 1991 to 2008. So what do we do with that data? You can clearly see a trend, but we need to be able to interpret the data. So we chose to use the mean. The mean is just half of those lines are above the line and half of the lines are below the line. So that's the mean. If we clean out the data and get rid of the noise, we now have what the literature says is the curve of how local anesthesia works in inferior alveolar nerve blocks with lidocaine and epinephrine. I wanted a sanity check. Has anybody else done a meta-analysis like that? And it turned out that Al Reeder and Neustein over at the endodontic program at Ohio State that have a very significant interest in local anesthesia, they've done most of the research. They did a very similar meta-analysis, except they excluded all of their data. So they looked at everyone else's data, not their own. We chose to look at everybody's data. So we had more studies in it, but if you look at the curves, they're essentially the same. So that's a good sanity check. How do we use the curve in our practice? So here we have the curve. If we go out to 10 minutes, that's the #1 response from dentists. There's actually a good reason where 10 minutes is a good time to check. That's the knee in the curve. The knee in the curve just means that for any given additional more time, you're not going to get that much more result. And so it turns out the knee in the curve for inferior alveolar nerve blocks with epinephrine is at 10 minutes, and it happens to represent 60% successful pulpal analgesia. Well, 60%, 6 out of 10 times, still seems like too much failure to me. So if you waited 15 minutes, you get out to 65%. Now, most people at the end of 15 minutes, if they're still not numb, so they're above the line of this curve, we're going to do something different. We're going to give them more anesthetic. We're going to do a different technique. Hopefully, we don't go back to the same spot. We want to go a little higher, a little east, a little west, or use a different technique like the Gao-Gates or an Akinosi, but you want to do something different because you want to get to work. So if it's past 15 minutes, we're probably going to give additional anesthesia. So where were we taught to manage local anesthetic latency in our practices? Well, we weren't taught in dental school. I don't know of a single dental school that teaches us how to manage that. They teach us how to give local anesthesia. They teach us how to treat patients, but they don't teach us how to manage the latency around our local anesthesia. So we work off of faith, right? We walk into the room. Sometimes we got our fingers crossed saying, oh God, I hope this time this patient's numb. And we also live with the curve, whether we knew it or not. So here we have this curve. Now we know how to understand it. We can bring that information back to our practices and use it. But I wanted to know, can we escape the curve? That's what I was looking for. So Articaine came into the market. Articaine is a fantastic anesthetic, and it came into the market in 2000. But does it make a difference? And so I wanted to know that. So first, go to the literature. We did another meta-analysis with all the same inclusion requirements except this one. Now it's 4% Articaine with epinephrine, so either 1 to 100 or 1 to 200, because that's the way it's packaged. No response to the EPT, mandibular molars and premolars, and multiple testing intervals over 15 minutes or more. And on that particular set of inclusion requirements, we only found 5 studies from even a greater period of time, so 1 additional year from 1990 to 2008. And so in only 222 subjects. So I'm thinking to myself, why so few studies compared to lidocaine? And perhaps it's because there is a controversy over 4% anesthetics, or particularly Articaine, having a higher incidence of permanent paresthesias after inferior alveolar nerve blocks. And so I thought perhaps that was it, but I went through with the meta-analysis anyway. And so we have our 5 studies. We place our mean, so 50% above, 50% below the curve. And that is the curve for Articaine. So now we have this curve. What we want to know is there a sanity check? Well, nobody else had done a meta-analysis, but Paul Moore at the University of Pittsburgh, great researcher, a great clinician, and a great teacher, had written an article in 2006, and he had one point in time for Articaine for mandibular blocks, and that one point was at 10 minutes, and lo and behold, it fell right on our curve. So that was our sanity check for Articaine. Now, if you take lidocaine and superimpose it over the Articaine's curve, we can see that they're essentially the same. It looks like Articaine starts off a little bit better, but it comes back to the curve. So is there a difference between Articaine and lidocaine with respect to successful local anesthesia or analgesia with inferior alveolar nerve blocks? And the answer is no. So why only 5 studies? Well, if you have a new drug and you have to prove equivalence. Once you've proved equivalence, if you are only equivalent, you really don't want to do more studies. So that's probably more the reason than the controversy. And they both work well. This is as good as it gets in dentistry. So if we go back to the commandments and we look at 5 to 7 minutes and we're looking at strictly pulpal analgesia, we go 34%. So 1/3 of the time you should expect to be successful at 5 minutes. That's only one in 3 patients. You get out to 45% at 7 minutes. So less than half the time you should be successful. Now we need to start thinking about that in the new normal, and we'll get to that. But I still wanted to escape the curve. So can you escape the curve with buffering? Buffering anesthesia, local anesthesia, has been around in medicine for 100 years, but it hasn't been around in dentistry, mostly because we have our little cartridges of anesthetic that are a fixed volume, so we haven't been able to do it. But let's take a look and see if it would make a difference. So Stan Malamed and I did a study back in 2013, and this is the plot of that study over time. And you can see there's a significant difference. Now, this is also pulpal anesthesia. This is not soft tissue analgesia. This is pulpal analgesia. And if you plot it against the curve of articaine and lidocaine, you can see visually that there's a significant difference between the two. But let's bring it to what we do in practice. So we've already talked about if we get out to 15 minutes and it's unsuccessful, we still are not numb, we're going to do something different. We know that 65% of the time that's the case. So 35% of the time we're doing something different at 15 minutes. If we look at 2 minutes with buffered lidocaine, that success rate is 71%. So it's a little better than 15 minutes with unbuffered. Is it 100%? No. But at two minutes or less, your patient should be numb. And if you're using your endo ice, you can find that out very quickly. At 2 minutes, that's equivalent to 15 minutes. If they're not numb, you may not be in the right place. Time to give them another injection. I was taught in dental school to always give 2 blocks. I don't do that anymore. I give one. If it's not successful at 2 minutes, I give the second one. And that one was almost immediately successful. So I'm able to work in 2 or 3 minutes under the worst circumstances. So that is escaping the curve. And that gives us options. As long as we have those options, we should know a little bit about the science of buffering. So at a real high level, I want to go into that. Why would we buffer local anesthetics? Well, all local anesthetics are highly acidic. That means that they're packaged in an acid form. And the acid that they use is hydrochloric acid. So when you look at anesthesia, it's lidocaine HCl, articaine HCl, any anesthetic HCl. That's hydrochloric acid. It's a very, very acidic molecule. It's formulated with that. If it has a vasoconstrictor, then there's preservative in there, and they even put more hydrochloric acid because the vasoconstrictor, epinephrine, oxidizes easily unless it's in an acidic environment. And all of this acidity adds to the shelf life. So if they didn't use hydrochloric acid and they tried to package anesthesia at physiologic pH, they'd have about a week from manufacturing to Benco, and from Benco shelves to your shelf, and from your shelf into the patient. It just would never happen. They need a minimum of 18 months shelf life, and so they have to have this acidity in order for the anesthetic to be effective. The problem is local anesthetic doesn't work in vivo or inside the body until it's raised up to pH of 7.4. The body has to do that. So we're asking the body to do that for us. But if we can precisely buffer outside of the body or in vitro, we can get some really astonishing results. First of all, on a mathematical level, we're going to create 8,000 times more of the active form of the anesthetic, the deionized form of the anesthetic. It's not 8,000 times more potent, it's 8,000 times more active at the time of injection. If the patient got numb, they achieved that 8,000 as well, but it took them time. We're going to do it right at the time of the injection. That's going to take the patient's physiology out of the equation. In other words, we're not going to make the patient work anymore. So that's going to take them out of the equation so we don't have to depend on them. We're also going to dramatically reduce injection pain. We're going to take this pH of 3.5. So think about it. We're sticking a needle in, and then we're bathing that needle in lemon juice. Now we're going to still stick the needle in, but we're going to bathe it in the pH of water. So it's a lot more comfortable. we're going to create dissolved carbon dioxide in solution. So when you combine sodium bicarbonate, which is our buffer, it's also our body's buffer. It's what's already in the patient being used. When we combine that with hydrochloric acid, it liberates carbon dioxide. Carbon dioxide is the most rapid form of transient analgesia known to man. So if you can just have a drop of anesthetic in front of the needle, the whole way the needle's going in, the patient will not feel it. That's not the local anesthesia, that's the carbon dioxide. Because of that, you want to buffer your anesthesia and use it right away. And that gives you the maximum for carbon dioxide benefits. The other thing buffered anesthetic will do is it will help us get the infected tissue numb. Tissue that's infected, whether it's a periodontal infection, an endodontic infection, has a pH as low as 5.0. That's what happens. It gets the pH of our tissues go down. It can get as low as 5.0. And when you put the anesthetic in at 3.5, the highest it can get is 5.0. Well, pH is a logarithmic scale. There's still almost no deionized form of the drug or active form of the drug at 5.0, so we can't get them numb. So what have we always done? Send them home with a prescription of antibiotics, not to treat the infection. We all know the dentistry is what treats the infection, but to knock the infection down so we can hopefully get them numb and comfortable enough to have the procedure a few days later. Well, if your anesthetic is coming in at 7.4 and the pH of the tissue is 5.0, now we've got a great chance of getting that patient numb, and we can get the patient numb without sending them home with antibiotics just for the luxury of being able to get them comfortable. We can get them comfortable and treat the infection so they can go home without even maybe needing antibiotics. So it's a great opportunity for that type of patient as well. But when you buffer anesthetic, you have to manage variables, and this management is really important. So if we take this cartridge of anesthetic at 3.5, and any anesthetic that has a vasoconstrictor in it is packaged at a 3.5, and we want to get it up to that green band, which is physiologic pH or 7.0, if we under buffer it, we're going to get no improvement because we haven't hit the upslope in the logarithmic pH scale. If, however, we over buffer it, we're going to get precipitate. So the anesthetic is going to fall out of solution, and we don't want to inject precipitate because that can damage tissues, including the nerve. We also have to buffer correctly the ratio. How much buffer do we put into the anesthetic to get it to where we want to be? That ratio is critical because we also want to get the right amount of carbon dioxide, which we've already said will make the injection more comfortable, but it not only does that, it's a catalyst to make local anesthetic work more effectively for the patient. So we really want to get that dialed in correctly. But we don't want to overdo it and put too much buffer in because that will create a solution that's hypertonic, and tissues don't like hypertonic or salty solutions. So now we have these dials. We want to dial in the best pH we can. And if we do, we can hit the target zone every single time. If we're really precise, we could call that a bullseye and make it the best anesthesia we can at this time in history. And that's what we want to do for our patients, is make the anesthetic the best it can possibly be. Because all of our procedures that require analgesia need to be fully anesthetized. And we want to be able to do it now efficiently so that we can see one patient at a time and be able to still run an office practice. So what are our options? So now we've decided, yeah, let's buffer our anesthetics. We have options. There's options out there. What are they? Well, the first would be do it yourself. So you could go out and buy medical grade sodium bicarbonate. It comes in a vial, not in a cartridge. And you have to buy some hypodermic needles, syringes and needles, because you're going to have to be able to transfer the bicarbonate into the cartridge of anesthetic if you're going to use a cartridge-based system with a stainless steel syringe. And you're going to have to also take some of the anesthetic out in order to get the buffer in, because the cartridge is a fixed volume. So that's do it yourself. You could use the Onset system. That's the system that we brought to market. I'm going to show you that I think it's the best system out there, but there are 3 ways you can buffer, to be fair. And the third is the Anutra system. Anutra uses their own syringe. You can see that plastic syringe on the right. You know, we were all trained with cartridges of anesthetic, and we were trained with the stainless steel syringe. And although, you know, it's a little medieval looking, it has a tremendous amount of feedback, and plastic syringes don't. And so a lot of dentists have said that that syringe is one that they struggle with. One advantage of that syringe is that you can draw up, I believe it's 5 cc's of anesthetic, so you're not hooked into just 1.7, 1.8 cc's like our cartridges. But it is a system. You can only use lidocaine with epinephrine. And those are the 3 ways you can buffer your local anesthetic. So do-it-yourself technique. If you're going to do that technique, then you need to have your cartridge plus the first syringe. You want to stick that syringe into the cartridge and withdraw a certain amount of anesthetic. And then you're going to take your second syringe and you're going to draw up that same volume from the cartridge or from the vial of bicarbonate. And then you're going to place it into the cartridge of local anesthetic and then place the local anesthetic cartridge into your syringe. That takes time. You have a lot of equipment out. And as we know now, we want as little equipment out as possible. So it is a little bit cumbersome to do. And there are variables you cannot control for. The bicarbonate that you're buying has a very wide pH range of 7.0 to 8.5. Remember, that's a logarithmic scale, so it's a massive difference from one side to another. And if you don't get it near right on the physiologic pH, you're either going to be under and not get the advantages, or you're going to be over and you could have precipitate and cause damages. So if you look at this, it's fairly simple, but it's kludgy. It's not precise at all. It does take time. It may save you money, but I'm going to show you that if you do it correctly and as safe as possible, I don't think it's even going to save you money. And you are definitely going to have inconsistent results. Well, we already have inconsistent results with local anesthesia that's unbuffered. Why would we want to buffer it and still have inconsistent results? You could potentially harm the patient if you have precipitate. You want a system, if you can, that guarantees you won't have precipitate. And if you do, you could have some edema as well. But with precipitated local anesthesia, you could actually have paresthesia as well. So what would that look like, just so you know? Here's a cartridge of local anesthetic that's being buffered by sodium bicarbonate that's pH is too high. And when it goes into the cartridge of anesthetic, you see the precipitated anesthesia becomes like a snow globe, and you don't want to inject that. So if you're doing it yourself, you want to monitor those things very, very quickly. So if we look at the 3 different options, do it yourself. If you do that correctly, what I mean is when you buy that vial of bicarbonate and you start drawing out the bicarbonate, you're changing the pH inside that vial every single time because it's a volatile compound and you're sucking air out of the vial. So you're changing the pH of the bicarbonate, which is making it get higher and more dangerous. So I wouldn't recommend you use it more than 4 or 5 times within a day or 2. And if you do that and you put together that with all of the syringes you have to buy and the needles you have to buy, it ends up being about $4.10 per injection on an average. Could be a little bit less, could be a little bit more. I strongly would recommend that you don't use every drop of that 50 mLs because by the end you will be having a lot of problems. There is prep time, there is a learning curve, and the bicarbonate can't be controlled, and hence your inconsistent results. And then, of course, like I've said, you could have some complications due to the over buffering. With the Onset system, it turns out to be $3.19 per injection if you used every drop. What I like to say is, you know, when you set our pen up, it's a multi-dose system. Each time you set the pen up, it can buffer 18 cartridges of, 20 cartridges of anesthetic. And so it's about $13 a day to have all of the benefits. Once you set the pen up, you can use the buffering solution for a full week, 7 days. And so most people use all of that up, and it ends up being about $12 a day, $13 a day for the system for all of the benefits. You don't have any plastic. It controls for the pH exactly. We figured out how to make bicarbonate at exactly the right pH and then hold it there indefinitely. We own all the IP on that, and we figured that out when we brought that to market. So it's a very consistent result that you're going to get. The Anutra system, that turns out to be about $5 per injection. You have a learning curve because you have to learn how to use a new syringe. And I haven't tried it, but from what I understand, people have had struggled with that syringe. So saying that, there are some advantages to the syringe, but you definitely have to learn. You only can buffer lidocaine, and it is no different than you doing a do-it-yourself. You're going to have inconsistent results just because they can't control the sodium bicarbonate. It's going to have varied pH. One other disadvantage of lidocaine in a 50 ml vial, because that's the way this comes, is the other disadvantage is that there's methylparaben in that because it's a multi-use system, they have to have a preservative. We took methylparaben out of the cartridges of local anesthesia in dentistry in the 80s, back when I was in dental school, because they were having so many complications as a result of that when local anesthetic was injected into the face. So you are putting that back into the solution because it's a multi-dose vial. So saying that, here's your 3 options and approximately what it would cost. If you use the Onset system, you can buffer all your anesthetic. The only one I wouldn't say buffer is bupivacaine. That's Marcaine. That's a long-acting anesthesia that's really good for post-operative pain control. It's not very good for pulpal anesthesia anyway, and so there's no need to buffer that, but you can buffer all of your favorite anesthetics. So you don't have to change your technique whatsoever. You can use the exact anesthetic that you're also already using. Last year, in March, the cover of JADA was efficacy of buffering local anesthetics. They were looking at pulpally involved teeth, so that's hot teeth, if you will, symptomatic irreversible pulpitis, and it showed a 2.3% chance, a 2.3 times more effective with buffering anesthetic with pulpally involved teeth than unbuffered anesthetic. If you talk to endodontists, or if you're an endodontist yourself, the AAE published a study that showed they surveyed endodontists, got a very high response, and they asked, if you have a hot mandibular molar, how many cartridges of local anesthetic do you use, and how long does it take before you can work on the patient comfortably? And 5.5 was the number of cartridges that endodontists do for mandibular hot teeth, and 30 minutes before they start. Now, with hot teeth, you're not going to get 1 or 2 minutes, but you're going to get 10, 12-minute results, and you're going to dramatically reduce the amount of anesthetic that you need, because local anesthesia that's buffered is more efficient. That is the hardest tooth in the, that's the hardest thing in the body to get numb, is a pulpally involved tooth. So, you know, under our worst circumstance, buffering anesthetic is a big help. So why would we want to use key reasons for using Onset? Productivity and performance. Look, if we're going to see 1 patient at a time, we need to be productive. I've been seeing 1 patient at a time. I took a 4-day schedule and brought it down to 2.5 days just by changing how I give local anesthesia and not waiting for it and seeing 1 patient at a time, because I'm 30% more efficient. And so I would put my production in 2.5 days up against almost anybody's in a full week. And you can do that. You can also save an hour or 2 a day. But under these circumstances, you can go right to work, see 1 patient at a time, and be productive. And that's the key in the new normal. Reduce your stress and practice flow. Let's face it, if you have consistent results with local anesthesia, your day's going to be better. Your patient's days are going to be better, and your days are going to be better. And then we're going to improve the patient experience. We're going to have a much more comfortable injection, which is patient's #1 concern, is that the shot hurts. So if we can fix that for them, we're going to make a patient for life. And we're going to be able to get them out of the office faster. And patients are looking for that right now. They know that their mask is going to be off when they're in the dental office, and they want to be as safe as possible. So get me in and get me out. And if you sit with the patient, you're 30% more efficient, and you never leave them, their time in the office goes down dramatically, and they're going to notice. My patients certainly do. So that's important. So if we put all of this together and we use the tool of buffering local anesthetic, we truly can seat, treat, and complete. And that's going to allow us to dramatically reduce the amount of PPE that we're using. It's going to allow us to not be the vector of infection by leaving the operatory multiple times even once during an appointment. So we don't want to be the vector of infection. And it's going to be able to allow us to maintain our practice volume and our revenue, which is really important in times like this. So that is giving the patient the injection, seating the patient, giving them the injection, going right to work, confirming pulpal anesthesia, and finishing up that procedure and moving on. The patients will be much happier. I think you'll find that your practice gets, once you get used to that, you're now saying, wow, this is actually a better way to practice than before. I'm not running around as much. So now we have a problem we need solved, and buffered anesthetic is a way to solve that problem. So I want to thank everybody for being online. It's been a pleasure working with Benco. Like Chuck said, we've had a long relationship, and I just love the Benco company. I'm sure you all do too. That's why you're with them. And so with that, I want to say this is the end of the lecture, but I have a couple of things that I want to talk that are outside of the CE part of it. And that is, if you're interested, buy your On Pharma's Onset from Benco, and you've got the buy and try. So buy and try with Benco means you have 120 days to buy a kit, use all 80 injections, and decide whether it's for you or not for you. If you decide it's not for you, you can send it back. You get a full money back guarantee. I don't know of any other product you can do 80 times to figure out if you like it. So what I would say, because of that, and like I said, I have a financial interest in this, but really I also have an interest that patients are getting good care and that dentists get to do their business and be productive and be profitable so we can stay in business. And that is, give it a try. Just order it. Try it 80 times, and I think that you'll love it. But if you don't, there's no risk whatsoever. So it comes with the Onset mixing pen, which you use over and over. And then the reusables or the disposables are the cartridge connectors, which allows the anesthetic to be taken out and the bicarbonate to be put in. And then the cartridges of bicarbonate, which are set at an exactly correct pH. If you have any science questions, there's a lot of data on our website. There's videos, there's plenty of research and papers that we've done and other people have done. So you can take a look at that and do your research. If you have questions, you certainly can call us, but most importantly, get a hold of your Benco rep and they can walk you through it as well and buy and try. So Chuck, I want to say that's all I got.
Dr. Mick, that's awesome. We have a couple of questions if you have a few more minutes.
Absolutely.
Question number one, does this work in a pediatric setting? So does it work on children?
Absolutely. So it works on everybody. I think in pediatrics, you get even more benefits, to be honest with you. And the reason I say that is, in pediatrics, what are we concerned about? Well, we're concerned about a number of things. Number one, we're always concerned about how much anesthesia we give, right? Because that is a little patient and we have smaller amounts of anesthetic that we can give. Well, with buffered anesthetic, because it's efficient, you can give less local anesthesia. You're also diluting the anesthesia by 10%. So saying that, it's safer for the patient with regards to how much local anesthesia you're giving. So that's number one. Number two, when pediatric patients only have a fuse, they only have a certain amount of time before you've lost them, right? And so if you give anesthetic and go do something for 15 minutes and come back, you've already lost them and you haven't even started the procedure yet. If you tell them what you're doing and you don't hurt them because the injection is more comfortable and you go right to work, you're finished before their fuses run out. So even management cases get easier. So it's fantastic for pediatric dentistry.
Next question, how does the cartridge pen get cleaned?
How does the pen get cleaned?
Autoclavable? It's
Yeah.
autoclavable.
So there's two parts to the pen. You have the green portion, which is autoclavable, and then you have the black portion, which is you wipe that down. If you want to go from patient to patient, you can also take a slow speed sleeve and put it right into the slow speed sleeve, and then just go from patient to patient, and you're using the barrier technique.
Great. Anybody charge extra for this?
It's interesting you ask. So, there's, I'm actually working on getting a code for buffered anesthetic. That takes quite some time. But I will tell you that, in my particular practice, we are charging $20 for every patient that comes in, and we're calling it a safety and infection control fee. And we tried to figure out what are the additional costs that we're putting in. And one of those things is buffered anesthetic, along with all the PPE equipment and so forth. And so that will more than make up for what we're charging. So
basically wrap this into
charge
your
anything
fee.
you want. It's not covered by insurance at this point,
Right.
but at some point it may be.
But you can wrap this into an overall infection control fee.
Yeah.
Okay, great. Okay, thanks. Let's see. How should a doctor change his or her schedule to account for using this product? So in other words, that's the biggest change is
Sure.
now that I can get working on the patient right away when I sit down, how should I work with my front desk folks to try to change the scheduling?
So great question. I used a practice management consultant. Her name is Cindy Ishimoto. She's written some papers out there. I believe they're on my website. You can take a look at that, which will give you some great information. I'll just tell you real quickly, when I was buffering local anesthesia in my early stage and doing all my research, she came in and I said, hey, Cindy, I want you to watch me work because I want to know if what I'm doing is of benefit to other dentists. And I was just naturally giving anesthetic. I didn't tell her what I was doing. I didn't show her. I just said, watch me the way I work, gave anesthetic, checked to make sure they were numb, went right to work, went on to the next patient. And she's the one who said, look, I can save you an hour to 2 hours a day. I don't know what the hell you're doing. She's a hygienist too. So the first time I did it, she was like ready for the patient to jump out of the chair, and not a single patient over a week period of time jumped. And so she said, I can save you an hour and a half to 2 hours a day. I took that 2 hours a day and took a 4-day schedule, and made it 2.5-day schedule. But how you schedule is initially you want to make sure you have plenty of time. So you're instead of scheduling in serial, which means that you have patients in different rooms, you can use one room, you can use 2 rooms that are overlapping, but you're no longer seeing patients at the same time. And so you've got to figure out how long do things take you to do. So for instance, if a crown prep takes you an hour right now, let's say, and you're 30% more efficient, you could jump right in and say, I'm going to schedule 40 minutes. I wouldn't do that at first. I'd make sure that it's 40 minutes for you because you still have all of the things that you have to do. But because you're not being interrupted, you can do things faster. So initially, I would schedule 1 patient at a time, which we have to do anyway because of COVID. And now you can, as you're working, you can start without, let's say you're not going to use a consultant. You just start reducing the amount of time per procedure.
Excellent, thank you. And by the way, one thing you didn't really talk much about, but I just want to reinforce is this idea that you don't get interrupted so much just makes you do better work, because it's what we do in dentistry is very concentration important. It's important that we concentrate. And with this product, it means you can concentrate a lot better. So I think that's an underrated benefit of the Onset
Absolutely.
system.
Yeah, you know, when you're uninterrupted, you're much more focused. So you're more efficient on the time side. I was focusing on that, but your accuracy dramatically goes up as well.
Yeah. And how about when you do hygiene checks? You do hygiene checks at a different time? So
yeah.
in other words, I used to inject, then get up, then get back down. So how do you do that in your practice?
Right. So in my practice, first of all, I like to make sure everybody knows I'm not doing a hygiene check. Okay. I don't check my hygienist. I know they're awesome at what they do. I'm doing an exam. I'm examining the patient. So we all call it a hygiene check, but it should be called an exam because that's what we're doing. If I was checking my hygienist, I should get a new hygienist. Okay. So if you consider it's an exam, then you can go in at any time. You can go in the first minute, you can go in the last minute. So in between any patient, I check 2 of my hygienists every time. So I don't care if they've just seated them. They haven't even said hello to them. I sit down, I say hello, I do my exam. That's what they're there to see me for. Hygiene is there to take care of their teeth. Now, in an ideal world, I like to have my hygienist having done their own exam first, and I walk in and I can get more information from them, but I'm still examining the patient. So I can do it from the first moment till they leave. And so generally speaking, the average dental appointment in the United States lasts 44 minutes, and the average hygiene appointment is an hour. So if you think of that, you always have an opportunity to check the patients. It's not just within what you're doing, it's on either side of what you're doing.
Got it. Thank you. All right, great. What do you do about a patient who only stays numb for 10 minutes? Is that a thing?
Well, if you're using a plain local anesthetic, so I'm not sure exactly where that patient, where that question comes from, and whoever asked it, you know, you can call me and we can go over it because there could be some technique problems. There could be the use of the anesthesia that you choose. So if you choose a plain anesthetic, so we have 2 of those on the market now. That is mepivacaine plain, that's 3% mepivacaine, and prilocaine plain, that's 4% prilocaine. And you give in maxillary infiltration. Pulpal anesthesia can be as low as 10 minutes, right? And so why do people use a plain anesthetic? And that's because some people don't like the little bit of tachycardia you can get from epinephrine, so they elect to use a plain anesthetic. The problem is when somebody feels it, so if your procedure is longer than 10 or 15 minutes, now they make their own epinephrine. And you can't control that, right? So I usually tell people that, you know, this procedure is going to be 40 plus minutes or 2 hours or whatever it is. I need you to be numb that whole time. I want you to be comfortable. You may feel the adrenaline for just a minute or 2, and then we're going to make you comfortable the whole time, and that's safer. And most people go along with that.
So a
Now,
lot of it is about communication and choosing the right anesthetic.
exactly. Right, right. And knowing you're using the right drug. So plain anesthetics are really for very short procedures.
Got it. Excellent. Thank you. Any side effects from this,
So
from the
yeah, so
buffering?
so
From
you know,
buffering?
I will tell you that I'm the chief medical officer for On Pharma, so I take every adverse event call. And whenever you try something new, you're looking at everything. But it's all the same adverse events that we get with local anesthesia. So can you get a hematoma? Absolutely. Can you get a little puffiness? Absolutely. Could you get paresthesia? Absolutely. Because those things happen. Is it the buffered anesthetic? Buffering is using sodium bicarbonate. If you use it properly, it's exactly what our body is doing. So it's very safe. So saying that, are there side effects? The side effects are exactly the same side effect you would have had in that particular patient if you hadn't buffered the anesthetic.
How about buffering for maxillary infiltrations?
Yeah, so
Yeah.
I would never treat a patient without buffering personally.
Got it. So you buffer every shot,
drinking the Kool-Aid. Pardon?
every injection. You buffer every injection.
I buffer every injection because I'm not just doing it for efficiency. I want it to be as comfortable as possible.
Gotcha.
And so, having a patient say, I didn't feel that at all is an opportunity for you to say, send your friends that don't like going to the dentist. So that's always a marketing opportunity. But beyond that, if you look at the same data, this was a short lecture, so I couldn't give you the maxillary data. I don't find it as, people are always much more concerned about the lower jaw because it's harder to get numb. But if you look at it, it's still 3 to 5 minutes, even for soft tissue. So that means it's longer than that for pulpal anesthesia. With buffered local anesthetic in the maxillary arch, you're looking at, usually by the time you take the needle out, you can check the tooth, they're numb, they're ready to go. So should you buffer maxillary infiltrations? I say absolutely. Should you buffer palatal anesthetic? Absolutely, because that's one of the most painful injections we give. So from my point of view, I think everything needs to be buffered so you can treat an upper tooth and a lower tooth exactly the same. That helps you schedule.
Got it. All right. I don't think we have any more time for questions, so we'll post the answers to these questions later. Dr. Falco, thank you very much for being here today. It was a fabulous program. We very much appreciate it. Kay, I'm going to turn things over to you and say thank you very much for having us today.
Well, thank you both of you. I'll just say thank you, Kay, real quickly to Chuck in case he jumps off, and thank you, Kay, for all you do. So,
Kay, you're on mute.
Boy, that's a mistake, right? Thanks, Chuck. Thank you so much. Again, it was a great webinar, great information. And really right now when our schedules are so tight, it's a great way to change a whole day, right? So guys, with that being said, I would like to give you an update of some upcoming webinars. And I want to tell you, if you'll use your phone and you can scan the QR code on this screen, it will give you a list of all of the upcoming webinars because we really have some good ones coming up. So scan that. That'll give you all the updates. Go ahead and switch the slide. Super excited about this webinar that's going to be happening next week. It is Dr. Kim, and she's going to be talking about the Soleo laser. There are a lot of things that we can do differently now, chairside, to actually help with our patients and actually make our procedures run smoother. So if you're interested in even looking at the laser and you want to know more information about the Soleo laser, Dr. Kim's been using the Soleo laser for a long time, and she's going to be giving us some great information. That's going to be on July 15th from 7 to 8. And this is going to be an amazing webinar. Every time I speak, I have someone who comes up to me and says, you know what, my data was stolen last night. I came into my office today, I turned on my computer and there was nothing. So we're going to talk about, Chris is going to tell you a little bit about what happened to her when she returned to her office after being closed through COVID, finding out that her data was completely gone, completely actually hacked, I guess you can say, and she couldn't get it back. They were wanting to charge her, I think, $50,000 to get her data back. Deborah Carr walked her through the whole thing, and so we're going to be really giving you some good pointers on what to look at when you go to protect your backup, to make sure that your computer is protected and that you are protected, and that you save your office from going through this turmoil that she went through. So that webinar is going to be July the 21st. It's going to be from 6:30 in the afternoon to 8. You don't want to miss it. Really a true story that just recently happened, and it's going to give you some really good checklists of what to look for, because this company was actually referred to them from their dental society. So it's pretty amazing. And then again, we need to have an update about what's going on in our offices right now. What's the new CDC guidelines? And so Rick Cohen is going to be giving us a great update on supplies, where we stand, the chain, what's happening, what's new. He's always on top of that. So he's going to be giving us an update on that. And then we have Leslie Canham, who's going to be giving us an update on, HIPAA guidelines. Has anything changed? What do you need to be doing differently? That's going to be Wednesday, July 22nd from 1 to 2. So you don't want to miss that one. Then we have some upcoming workshops. Workshops are a little bit different. They're 2 days. They're a total of 4 hours. And the first workshop that we have coming up is going to be on medical billing. So if you're interested in medical billing, you don't want to miss Laura Owens. She's going to be able to walk you through how to make sure your office can do medical billing. I think we leave a lot of money on the table, and learning this can change your whole life. It can really make a huge difference in your pocketbook. So you may want to join us for this one. It's $125 a person. Again, that covers the entire workshop and also your workbook. That's going to be July the 17th and July the 24th. And again, both those sessions are from 12 to 2. Then we're going to have Roy Shelburne on. Roy is going to be talking about dental insurance, what to do to make sure that you're getting paid. He's going to be going over how do you negotiate now with your PPOs, and how, to be able to get the PPE covered and what to do about that. So Roy is going to be giving us a lot of great tips, and he also is going to be giving you an amazing book. So if you're interested in learning more about dental insurance, you don't want to miss this webinar on August the 21st. Through the 28th, again, 2 days from 12 to 2. And then last but not least, Catherine Itel. She's a great communicator. She's going to be really talking about in-office communication and communication with your patients. This is going to be a workshop that's going to be on September the 11th and September the 18th. You're not going to want to miss this one. Please make sure, if you want to improve your communications either in office or with your patient, sign up for this webinar, for this workshop. If you have any questions or comments, please share them with us. We want to know what you're thinking. My name's Kay, and we really appreciate you coming on. Our email address is practicecoaching@benco.com. Again, that's practicecoaching@benco.com. Any questions or comments, please send them our way, and we will see you next Wednesday. Thank you very much.